Hi, everybody, and welcome to the PHU Clinical Academic Hub podcast. My name's Chantal, and I'm a consultant clinical academic, which is essentially a clinician who is leading research relevant to their speciality. And I'm a physio, and I specialise in prosthetic rehabilitation. With me on the podcast journey today is Rosalind Austin, a cardiology clinical academic nurse. And so this is the second of our Reviewing the Evidence series, which is aligned to the monthly educational hot topics and designed to complement any upcoming study days or events that you might be aware of. And we'll be producing a podcast every month, reviewing an article related to each hot topic, and will be accompanied by a PHU specialist clinician in the field. So today's topic is dementia, and our lovely specialist is Emily Oliver. Hello, Emily.
Hi, thanks for having me.
You're very welcome. Thank you for coming. So Emily, can you tell us a bit about yourself and about anything that's going on this month?
Yeah, of course. So hi everyone, as Chantal said, I'm Emily. I'm the lead nurse for dementia here at the Trust. I'm a mental health nurse by background, and I'm also a clinical academic. So I did a PhD a couple of years back now, focusing on care for people with dementia in hospital and how the work system affects nursing staff ability to provide compassionate care. So this month within the Trust, it's very, very busy, winter pressures at the moment, but I'm putting out a newsletter every week with some learning about what's going on, focusing on a different topic. So this week it's identification and diagnosis, and then we've got person-centred care, and then we've got meeting the unmet needs, so how we support patients who find it difficult being in hospital.
That all sounds fantastic. So hopefully the paper that we're going to talk about today will give you another kind of view on this topic for this month. So Emily's chosen a paper for us to review, and it's called Routines of Resistance, an ethnography of the care of people living with dementia in acute hospital wards and its consequences. And so this is a qualitative ethnographic study, and so we're going to use critical appraisal tool to help us guide us through the process. So you can find the paper in the link below, but you can also find a link to the critical appraisal tool below as well. And there are loads of different critical appraisal tools available. When we were looking for an appraisal tool for this study, what we found is actually when we're reviewing qualitative research, a lot of the appraisal tools tend to lump qualitative methodologies into one and review them all in the same way, whereas quantitative tools tend to focus on cohort studies or randomized controlled trials. And so that would be one of the things to bear in mind when we're using a qualitative research tool. And the other thing that we found with the appraisal tools is that sometimes that they are designed as appraisal tools and sometimes they're designed as reporting tools. So what the authors might be expected to put into their paper as they're writing it up. And so the one we've got today is called the Standards for Reporting Qualitative Research, or the SRQR. The link's available below, so you can have a look at it. And I'd really recommend before we get started that you get the appraisal tool up on the screen or print it out, just because this one, you can see all my notes on this one, is normally we go through the questions, but this one has got loads of kind of information underneath that help you to answer the question, and you don't really want to hear me reading all of that. So if you've got that, you can refer to it. So before we start, we're going to ask Emily to just give us a bit of summary of the paper for anyone who hasn't read it yet.
Great. So as you said, Chantal, this paper is focusing on the routines of resistance in acute care setting for people with dementia. So as you said, it's an ethnographic study, and we'll go more in detail about what that means, but they used observations of care and ethnographic interviews as well. So we'll go on to talk a little bit more about that. It was based across 5 NHS hospitals across England and Wales. And the participants were people living with dementia and nursing team members. And what it explored is how the routine of the hospital impacts people with dementia and how that then affects the care that they're given. So it's a paper close to my heart. It speaks really closely to the findings of my PhD. So looking forward to talking through it.
Fantastic, and also highly relevant to the patients that we might see on a day-to-day basis on the wards of QA. Okay, so if we get started, we're going to go through each of the sections in turn and talk about the paper. And highlighting any positive things, but also thinking about anything we need to consider when interpreting the findings from this study. So the SRQR tool directs us to start with the title and the abstract. And so with the title, it asks whether there is a concise description of the nature and topic of the study, identifying the study as qualitative or indicating the approach. What do we think?
I think it ticks all round for this one. So the title is really in depth. It obviously outlines what the methodology is. It outlines the population. So it says people living with dementia, and it also outlines the setting. So it says acute hospital wards.
Yeah, absolutely. I completely agree. And then it really highlights as well that they'll be focusing on the care and the consequences of that care. So I think it was very clear from the title what's happening. Rosalind, anything you wanted to add?
No, I agree. Liked the title, was clear, easy to understand, and it gave me a good indication of the type of study and what the focus of the study was.
It then asked us to look at the abstract. So did it summarise the key elements of the study and using the format intended for publication? Yeah. Yeah, I agree. I think that included everything that was relevant from the paper was included in the abstract. So fantastic. Okay, right, let's get on to a bit more of the nitty gritty. So we then are encouraged to look at the introduction and think about whether they formulated the problem, described the significance of the problem, and reviewed any relevant theory and empirical work. And then also coming down to, did they then state the purpose of the research or a research question?
Yeah, so for me, just the first part of that question about looking at the background to the paper, the theory and empirical work. So this paper was published in 2018 and the references referred to are really up to date. So I think the 2015 you've got there, 2010, 2014, and knowing this part of literature well myself, everything that I thought would be referenced has been. So you've got Dewing and I think it's a Nordic name.
The pronunciation game.
That's a sort of a very pivotal piece within this literature. So yeah, I think that was well covered.
Okay. And so when we were looking at this, and so before we do these podcasts, we always have a bit of a chat just to think about what we might be saying. And one of the things that we talked about, particularly about the introduction, was about the end section of the introduction. So Rosalind, I don't know if you want to talk about what you've raised there.
Yeah, so I felt overall that the last paragraph of the introduction didn't belong in the introduction, and that what was actually missing was the so what. So they presented the stage, they got the context set, but then they didn't really overly focus on what their research problem was going to be and how they were going to look into it. They instead finished the introduction off by sort of defining what resistance was and how they were going to treat it within the study, which I felt needed to be in the methods versus the introduction. And I think as we'll get into the discussion a bit further, for me, that really solid clarification of the problem and their plan to look at it was really missing, and that made other bits of the paper harder for me to process. Being, this is the first ethnographic paper I've ever read, so that was a bit of a struggle for me.
Yeah, and so one of the things that we talked about as well that Emily highlighted is that in qualitative research, you wouldn't necessarily have a hypothesis that you might have in quantitative research, where you'd be looking to prove or disprove your hypothesis, whereas in qualitative work, it would be much more about exploring an area or trying to further understand an area. But at the bottom section here, you would kind of want to see that sort of aim. So what is the aim of the research? Yeah. Whereas what they also kind of came down to, they just kind of described what they did rather than give us any particular aim. So although it was very clear what they were trying to do, it was just that would have been nice to have that kind of research aim in there. So, okay, so if we go on and talk about the methods. So the tool then directs us to look at the qualitative approach and research paradigm. So does anyone fancy having a go at describing what a paradigm is? What a horrible question. Why would I do that to you? What, have a go.
Silence.
Every single PhD student in the land. What the hell is a paradigm? So, Shall I have a bit of a go? So I think with a paradigm, it would be that your approach to how you view the world and how you view how we garner knowledge about the world would kind of be your definitions.
Yeah.
And it comes into your what we would call your ontology, so how you view the world, and your epistemology, which would be how you feel that we gain knowledge about that world. And in qualitative research, it's really important that we have that kind of background understanding of where the research is coming from, because it helps us to understand whether the approach fits well with that paradigm, and whether the way it's been analysed and it's been developed also fits, because it needs to be coherent. So what you wouldn't want to do is have a question that had a yes or no answer. So I would like to know the answer to whether this happens in this situation wouldn't necessarily be appropriate for qualitative research, where you'd be looking more to try and understand why that was happening and the experiences of people that it was happening to. And so having that information is really useful to us. So what did we think about what they put in this paper about their approach and paradigm?
So I'll hop in first before Emily goes, because Emily has a different perspective than I do, having known the dementia literature and being familiar with the methodology. So being novice at it, aside from like a class ages ago where they introduced what ethnographic was, for me, I felt like what they did is they threw the terms in there so that they could tick that box according to the reporting standards, saying that they declared their paradigm. But as somebody who isn't familiar with what those words mean, I found I really struggled, because they did try and justify it and talk about how it fit in with the context and stuff like that. But because for me, what is meant by ethnographic approach and what that means for how you see the world and what you believe about knowledge gaining, I'm like, it was too far away. So then I struggled to be able to evaluate whether or not that approach matched the context of how they were going to go about doing the research or not. So I personally, as a novice to this approach, could have used just a little bit more drip feeding on what that meant.
Yeah, because I think in terms of what they were looking to do, it appeared that ethnography fitted quite well with that it was coherent approach. But what we didn't have is any kind of detail about that to help us understand it. So Emily, did you want to add anything about that?
I was going to add something in. So I think if I reflect back, so I did an ethnographic approach for my doctorate, and if I reflect back on what that entailed in terms of word counts, I think it was probably, a whole chapter, probably 10,000 words on what my paradigm was, what ethnographic research is. For me, within the constraints of the paper, which is probably 3,000 word limit or something, or up to 7,000. I think they did it quite well, but I understand, reflecting back, that I already have that prior knowledge. Whereas for people who, from an outsider, if this was about quantitative research and a paradigm within that, I would be exactly the same as you guys. I would have no clue. So I completely see it from both sides.
Yeah. And so I think that raised that kind of point that if we're writing anything up, how important it is to be really explicit about what we've done and why we've done it, so that anybody reading it can be able to look and critique it and see whether they have confidence in what the findings might be. So that sounds really interesting. Okay, so we think that it fits really well, ethnography, but we would have, in hindsight, liked a bit more information. So the next question is about the research characteristics and reflexivity. So we were talking a lot about reflexivity this morning. Does anybody want to have a go at saying what reflexivity is and why it's important?
Yeah, I can give that a go. So within qualitative research, reflexivity is such a major component with that, because it isn't as black and white as quantitative research, in that there is a yes or no answer. Actually, myself, I can really try and limit all my biases, but because of my history, because of my ethnicity, because of the way I've been brought up, because of the role that I do, that will, without a doubt, have an impact on the way I see the world. So when you're presenting these results, you need to present who you are and what impact that might have on the research, because that will undoubtedly affect the way you see things. So reflexivity is the way that you prevent or not prevent, but outline your bias, your potential bias.
That
and
is
I think
knowledge almost. Yeah.
Sorry, say it again.
Acknowledge your kind of almost acknowledge what biases there might be there and lay them out for the reader. So yeah.
Exactly. And it isn't about that being wrong or right, and it doesn't make the research less or more valid, but it allows the reader to understand where you're coming from, to be able to make decisions about, or their own thought about this. So I reflect back on my PhD. So I was a nurse researching a nursing area or a nursing ward. So, my preconceptions about things that were happening, I have to make those clear, because I might have different judgments just because of the fact that I am a nurse myself. And I think we said within this, there is one bit on page 9 of the paper. It's like one line. So both researchers held PhDs and work within healthcare schools at the UK universities. They're not registered medical professionals and hold no regulatory duty of care. So they didn't go into reflexivity as much as I think that they should have, specifically because it is so important in qualitative research.
Yeah, definitely. I mean, it was really useful to know that they weren't clinicians. And so, because I think if you were perhaps a nurse or a therapist working on a ward, and you're much more used to seeing those things and might start and think of them as like, oh, that's normal and I can just accept that because I've seen that before. You might not note it. So knowing that they weren't clinicians means that potentially they could be looking at things from a much more kind of sort of blank canvas, really, and able. So that was really useful information to have. But it would be really much more useful to know who they were as individuals, what their backgrounds were. Were they nurses? Were they therapists? Were they doctors? But also, one of the things that wasn't very clear in reflexivity is who are those people, who were they, and what did they do in this study? So which ones were doing the data collection, which ones were doing the analysis, because that helps us to understand the impact that that person might have had on the findings. And so, like Emily said, it doesn't make them any less important or any less valid. It just helps us to understand why that person might have formulated that view and whether we think that is credible. So,
yeah, absolutely.
Okay, and actually what we're talking about this morning, that lots of qualitative papers that you review really lack this reflexivity, and it's so useful to have like a lot of detailed information about the researcher, because we're really thinking about that researcher as a tool as part of the project. So, okay, context. So context is saying about the setting, the site, and any salient contextual factors.
So I think in terms of detail, so it outlines what type of hospitals they were. So it says they were teaching hospitals and general hospitals and a smaller general hospital. It outlines where they were situated and sort of what population they serve. So you've got their sort of inner city, large rural, urban catchment areas. It then goes on to talk about the wards that they use. So it was orthopaedic and acute medical. It doesn't outline the rationale for why they picked those wards. It does say that they used because they had a higher number of patients with dementia. Now, again, I've got a bit of insider knowledge because I know, or I've presented with Katie and Andy previously. So the reason I believe they didn't do it on older persons medicine ward, which is the area where we would see more people living with dementia admitted, they felt that actually those wards had a specialism and they were better trained, and they probably had more knowledge and confidence and competence of how to provide support to those staff. So they wanted to do it in areas which were more generalist. But again, that's my insider knowledge. Nobody reading this paper would know that.
Yeah, and again, that's that thing to really highlight there about why we need to justify those decisions so that us as readers can understand what was going on. And actually, so I had that down as a question, not coming from a dementia background at all, a bit like, oh, why would you not use APM wards? But actually, and that's a really valid point, which would have been great justification, but it just wasn't included. Yeah. So, okay. Rosalind, do you want to add anything else about context at all?
So I think I'll save my bits for context for when we talk about the results. But I think again, tying into that reflexivity piece, that context, it was that missing thread, which for me feeds into then what I thought about the results and how they wrote about it. Because while I could see they'd done lots of different types, again, because I didn't know who those researchers were, if, like Emily says, now that I have that bit of knowledge that they picked those places particularly because they thought the expertise of handling this patient group were lower, then that also makes me wonder, when they write about their observations, were those researchers who did these observations at this time, were they actually novice to witnessing and observing these interactions as well, and that then colors the language that they choose to describe that situation as well. So it all feeds in that while they did describe where it was, they didn't describe the larger context of who was making those observations, how those observations were being written about, and then how those were interpreted in order to come up with the results.
Yeah, absolutely. So we then go on to look at the sampling strategy. So how and why research participants, documents or events were selected. And so we talked a little bit about most of the sampling was around the types of hospital wards that were used, and in different types of hospitals. So some large acute hospitals, some were more like community-based hospitals. There's a variety of hospitals. But we didn't have any information about whether particular events were sampled. Now, Emily, I don't, again, also not done an ethnography before, but is that something that you would make definite decisions about what kind of like bays you might sit in, or what kind of patients you might observe, or do you just kind of go with the flow of what's happening at the time?
Yeah, so it's what's the word where it's evolving all the time?
Oh, okay. Yeah, no, I know what you mean. Almost a bit inductive.
Yeah, inductive.
Yeah.
So I think you go out with, because it's exploratory, obviously it's grounded theory, wasn't it? It was informed by grounded theory. So you go with an idea of what you will be looking at, but actually as the study goes on, what you saw yesterday will influence what you then go on to see. So yeah, it's more of a process. And I think, again, it's so difficult when you're limited within the word count of a journal, but potentially, you know, if this is a bigger paper or sort of a doctoral study, then that information might have been within that.
Yeah. And one of the things that came up in the next subject, which was ethical issues, is that obviously when they talked about doing observations, but they also talked about doing interviews, and they were doing observations and interviews with nurses, ward staff, but also people with dementia on those wards. And one of the things that I was really interested in is that there wasn't any information about consent processes for those patients who might have fluctuating capacity.
Yeah, I agree, Chantal. That was one of the biggest things that I was expecting to see in this paper, just because of my familiarity around how difficult consent in patients who might have altered ability to interpret information, as well as altered communication skills, differing levels of cognition and things like that, that they almost wrote about it as if they were only recruiting healthy individuals, but yet they did talk about interviewing patients and observing patients. And so I really would have preferred to see a bit more around how those more complex ethical consent issues were approached.
Emily, do you have any, like, obviously if you've done research with people with dementia before, what are our kind of options for in research for consenting people with dementia? Because we don't want to exclude them. We want for them to be involved and to have that opportunity to share stories, but also to take advantage of the, you know, research opportunities that are out there. So what options do we have for consenting people with fluctuating capacity?
Yeah, so there are so many options out there, and you're so right in saying that absolutely we should be involving this patient population in research, because we're doing research about them. You know, we need to be doing it with them, including them within it. So there are so many options in terms of just the information sheets that you give people. You know, you can do that by video. You have to think about sensory deficits. So could you have those in Braille? Could you have, a narrative over them so people can listen to them? For patients who don't have capacity or have fluctuating capacity, you can go to a personal consultee, so somebody who knows the patient well, whether that be their next of kin or lasting power of attorney, and they will say whether they would like to be involved or not. So that's just influencing your decision. And then the other option is actually professional consultee. So if somebody doesn't have a family member or friend who can advocate for them, then you can actually go to a professional who will know them well. I think you're right. I think one thing is actually we want that reassurance that that was well done, because actually these patients are vulnerable, but also it's really helpful for other researchers. So it's always a struggle to include this patient population in research. We want to know how you did it. You know, we want to learn from you how you did that. So it would have been helpful to have that within this paper.
Yeah, because often researchers come up with really innovative ways of kind of consenting and involving people, having different ways to present and to gather information from people. So yeah, it would have been lovely to see if they had developed anything to have that kind of shared. So, and I think that kind of goes on to sort of the next heading, which is about data collection methods. And the types of data collected, the details of that data and any procedures. And I think that came up again, didn't it? That interviews in people with people with dementia, we didn't really have any information about that. And it would have been nice to know if there was anything innovative going on, any approaches that we might be able to use elsewhere, and also to help us to feel confident that the people that were involved in this study were really happy to be involved. So.
I agree, and I think too in that section, the data collection methods, although they talk briefly about field notes, again, like how you define field notes and what that meant for them, and how those records were restored, were they translated into digital format, like the details of that, the transparency around that data handling, that data collection. That level of transparency was again not apparent in this paper, and again it could be, like Emily has already highlighted, just a limitation in the amount of words that you have, and that I think is a real struggle within qualitative research. And this paper isn't these for me, these things that I saw in it, it doesn't mean that this paper I think is bad. I think it's actually a problem that we have all throughout qualitative research, which ties back to what you said in the beginning around those reporting standards, and that they're generalized for all qualitative research and they're not specific to different types. Because I could imagine, an ethnographic compared to a semi-structured interview would be a very different word count in trying to summarize and do that. And so is it right that you only get 3,000 words for any paper? And should there be more flexibility in how we report, so that in general we can raise the standard of qualitative research by being more open and transparent without those one-size-fits-all restrictions?
And I think some journals now are offering submissions with no word count. And again, that works if that's in your area, in the journal that's got the readership that you want to try and reach, then that's great. But if not, then again, are you thinking, right, well, I'll go to a journal that has an unlimited word count so I can get my message out there, but I might not be targeting the audience that I want to do. And then that's down to you then to really think about dissemination and how you can share that link and for that paper and really get it out there. So some of the things that, there were some really good things in there, in that they talked about they gave us some good detail about the observations, that the length of the observation varied and why it varied, and they talked about this kind of approach of thick description, where their field notes were as detailed as they possibly could to make sure that the data was really rich and really useful. Yeah, so I thought the main kind of weakness there was around kind of understanding who had collected what data and how they'd involve people with dementia.
For me, I agree. One of the things, like, the more I've sort of reflected back on this article, I actually think that they did a pretty good job at explaining, like, the theoretical background and how they plan to apply that. But for me, the real missing piece was that practical application of those bigger theories and that translation, like being open about that translation piece of, okay, we did ethnographic, we did observations, this looked like, and we did interviews and that looked like, and this is how we consented and blah, blah, blah. Those greater practical details I would have loved to see, because again, it's like you said, Chantal, it's about sharing that learning so that in general research standards can just get higher and higher and higher, especially in such a vulnerable patient group.
Yeah, absolutely. So the next heading is data collection instruments and technologies. So description of any instruments, so interview guides or questionnaires or any devices, and whether they were altered and changed over the course of the study. So they discussed very much about field notes, didn't they? That their data appeared mainly to be in the form of field notes. And again, so I've already come from much more of being much more interviews and focus groups is my experience of data collection. And so then when I think about interviews, I always think, is there an interview guide? Do we know what they asked? But actually, Emily was telling us earlier that in ethnography, that can be very different.
It would just be more reflecting on the situation at hand, ad hoc questions. They'll be different to anybody who they go and see, so it wouldn't have sort of like a format of the interview guide. So people say, like, what is ethnography? How does it work? So Louis Theroux is an ethnographer, basically. So he goes into situations, he asks questions that come of the situation that he's in. So that is what these researchers would have been doing. So they're seeing something happening, they're asking probing questions to find out more, potentially they're reflecting with that person on what just happened. So quite informal, very exploratory, and intuitive in a way.
It's almost that kind of observation of the real world as it's happening, isn't it? And I think the grounded theory side of it is that kind of the initial, you might do initial observations and things would pop up and give you an idea, and then in your next observation you might try and explore that a little bit more so you can get a bit more, so you almost get this kind of development of your ideas and your observations based on what you saw before.
Yeah, absolutely. So without jumping into the findings, there's one of the themes is about medication. So probably what I assume would have happened is they're repeatedly seeing these episodes of resistance during medication. They might then say to a member of staff, is this normal practice? Is this a normal day for you? Does this tend to happen often? So they're exploring that a bit more, gaining that validity of what they saw the day before, like you said.
Yeah, fab. Okay, so the next one we've got was units of study, so number and relevant characteristics of participants, documents or events included in the study, and the level of participation. So I haven't written much about that actually in my notes. So and again, I think that's probably because there wasn't much information in there.
I was going to say there wasn't much there. So and I think for me, being novice to this style, that's where I really started to struggle, because although, and it could be, again, they were focusing on observing an event. And so they did describe how many events they observed in each ward and how many ethnographic interviews they then conducted. But being who I am as a clinician, and being this is the first sort of paper I've ever read in this style, I was like, but who did you observe? What did they look like? What did those patients look like? What did the nurses look like? If you said in the methods that you were going to interview anybody who ever intersected with the patient, how many porters did you observe versus how many nurses versus how many healthcare workers? Were there differences between those interactions depending on who that individual was? And that sort of for me, that more not generalizable, but just that context, that environment into which those observations happened. But I don't know if that's me and my lack of understanding about this approach, wanting something that shouldn't be there, because it's about that observation, not about the people who were in the observation. So for me, I just wasn't sure whether or not the tool was telling me to look for something that shouldn't be there, whether I was looking for something that shouldn't be there, and actually, is this how it should be reported? And that was a question the guide didn't help me answer.
Emily, any thoughts on that?
Yeah, so I think it would be impossible to report who every single person that they spoke to, what that number of staff
because the volume of people, because they're likely to have interacted with a lot of people.
But what they could have done is provided more context to the wards that they are providing. So actually, you know, the mean age of the patients that we saw was this. 90% of the workforce were female. The majority of the workforce that we saw were nurses, actually, and what their bandings were. So I think it would be a difficulty to actually report how many people were seen and reported on, but they could have had more context behind the wards that they were providing.
I think some of the so I think often in qualitative research, you get a list of participants, don't you? And it says their characteristics, and you don't always look at them as a group and kind of, you know, the number that might have this condition, the mean age of them and what have you. And that information is really useful, because what you want to understand is that the findings could only really represent the views and experiences of the people described in that sample. So for me, with people that have had an amputation, often, so I always really try and describe my sample really clearly, because the UK sample for amputation is predominantly dysvascular diabetics. But what you end up with in studies is a lot of young traumatic patients, and their experiences and views are likely to be very different. So it's understanding that background population to help you to know whether the findings here might be applicable to patients that you might see. So, yeah.
I agree. And I think it would have been useful not just to have the patient, a bit of generalization about the patients observed, but also the staff. Because, you know, a porter who's never come on the ward before is going to have a very different interaction with a patient who they've never had any resistance with before, versus a nurse who works there every day and has had lots of extra training around this type of interaction and stuff. So for me, that helps me be able to understand then what they observed in their findings around, was this a first time interaction, was it a millionth time interaction, or was it somewhere in between?
Yeah.
And it's actually, like, if you think more like higher level, so we already have, all of us are healthcare professionals, we know what NHS hospitals look like. But if you think an international audience reading this, they don't know it's publicly funded, they have no idea like what the population served is. So actually, we're thinking what we're describing is actually quite like the minutiae of detail in terms of the patients on the ward, but actually for somebody who's international, they need to know actually that the bigger, broader picture about what that hospital is, don't they? So
that's a really good point. I hadn't even thought of that.
And so I'm gonna jump on now just to talk about data analysis, and so about information about what the data looked like. So we know that most of their data was field notes, and they converted those field notes into Word files. So then they basically, their data was Word files, was typed up Word files. And so what did we think about their analysis? So what did they do with that data? We're all very quiet because we don't know.
We don't know.
Who's going to be brave?
So we got this kind of lovely study building and all this data, but then we go straight into what the results were, and so we don't really know how they got from those Word files to the findings that they presented. And I found the findings like really powerful and really interesting. And we talked about this earlier, and they really made me kind of think about things that I'd seen on the wards when I've worked as a physio on the wards. But the difficulty was that without that information about how they got to those findings, it's really hard to know how much confidence we can have in the findings, that the findings are actually valid findings and they're not just something that that individual researcher thought, or that we don't have that kind of depth of information about what they did with their data to turn it into their findings.
Yeah, that's exactly, I completely agree with you. Like, I went from reading the methods and them talking about like a generic overview of how they combined various high level theories. And then all of a sudden they're like, my findings are, and I'm like, well, those appeared out of nowhere. There wasn't that thread that helped me see, okay, well, they took the field notes and they looked for this, and they, they used their definition of what resistance was, and they coded separate events and then combined them and whatever they did. And I know that they did that because you can't come to themes without having done that work, but Emily, it wasn't there.
If you were with ethnographic data, so it's often in the form of field notes, isn't it? So is that what you would normally do to analyze it? Would you do like line by line coding and then look at bringing those codes into groups and subcodes and blah blah blah?
Absolutely.
So anyone would think I did this for a living.
You're completely right. It's absolutely what you would do. So start coding, start grouping those codes into themes, sub-themes, and then coming to your overall themes for the paper. I think, I don't know if we can touch on it here, but there's an issue about data saturation, or they call it theoretical saturation, and we had that discussion earlier. Is it theoretical saturation? Is it data saturation? And this is always a sticking point in qualitative research, because is there such thing as data saturation? Especially if I came into my office every day.
Tell us what data saturation is, just for anyone who might be listening who might not be familiar with the term.
Yeah, so in qualitative research, data saturation is when you're seeing the same themes coming through every episode of observation that you have, and there's no new themes coming through. Now, it's difficult to say, because the longer you watch, the likelihood is, just by the rules of possibility, you will see something new maybe 5 years down the line. But actually, how feasible is it to just continuously do a research study for the rest of time? And it's always contested. And I think we were talking earlier, so Braun and Clark, they're like the gurus over qualitative research and data saturation, and they say actually it isn't really a thing. We shouldn't be using that. We shouldn't be using that term, because it's a bit made up, really. It's a way of qualitative researchers.
We talked about that. It's almost like that kind of positivist, like, I need to know that I can definitely say that this is the truth. It's almost like that kind of approach slapped onto the top of qualitative research.
Yeah. So, and it doesn't fit with going back to the paradigm, because so most of the paradigms and the ontological views of qualitative research is that there are many versions of the truth, and it just depends on who you talk to and when that is. So we don't need to be putting data saturation on. Actually, what I'm showing you is a snapshot in time, and you can make your decisions about what you do with that information. So it seems a bit strange, but that isn't just in this paper, that is across the board in qualitative research.
But I think the problem with that is at the moment, the vast majority of the reporting guidelines for qualitative research require that you have some sort of statement around data saturation. So researchers, regardless of their belief about whether or not data saturation is true or possible, end up putting it in just so their work gets published. Yeah. Because it's
like a word, isn't it? A tick.
It's just a word. And but I think it goes back to like what we were saying about reflexivity, because that's similarly on all the reporting guidelines, is it becomes a tick box activity versus actually what did you do about it? So how did you determine to draw the line to say this is enough, we have enough to talk about? And was that because of the lens you've put on it, and you felt your question had been answered, and although new stuff might be popping up, it was sort of not necessarily relevant to the question, or going off on a tangent, or those sorts of things, and you actually felt that you had a strong enough argument that you could say we have a little bit more information about this question, versus just putting in a statement that says we achieve theoretical saturation, cite Joe Smith or whoever they've decided to cite, so that they can tick that box on that reporting guideline.
And sometimes it can just be a pragmatic thing, like you have 6 months to collect data, you've done all that, you've got to the end of 6 months, we have to stop now. So,
but I think it also goes back to your earlier point around actually what is important. Is qualitative research going to embrace its unique characteristics, and that it's not about finding a generalizable truth as a positivist or a quantitative research project is aiming for, or is it actually about exploring those individual perspectives and whether or not in those individual perspectives there's an overarching principle that you can see, and even though, you know, somebody might see it as turquoise versus azure, it's all blue. Yeah. You know, and it's about that ability to translate those individual perspectives into a greater concept.
Yeah. Yeah. And I think it's, you know, very historical that, you know, quantitative research is best practice, and we know RCTs are still the best, aren't they? We know that, but journals are still in that mindset. So that's why we as qualitative research, I'm getting on my soapbox now, but we have to try and fit our articles in the mindset of these journals that prefer quantitative research, when actually the richness isn't in terms like data saturation, the richness is in the stories that we're describing and the patient, like, you know, so yeah.
Absolutely. So if we move on to the results and the findings. So again, I thought the results were really interesting. The way they presented it was really powerful. They used some really nice quotes from their field notes that really highlighted some of the things. So I did really enjoy reading the results, and actually something that me and Rosalind were chatting about, which was I think sometimes when you read those kind of results and those kind of experiences, you might kind of think, oh yeah, that happens to me every day. But actually, by looking at it through the lens of a researcher, of other people, and framed within that paper, I think it makes it more powerful for you to think, actually, yeah, that does happen every day. But is it okay? Like, should that actually be happening? And do we need to do something about this? You know, do we need to look for change? And I think that's what's really useful about this kind of research, because it just shows you it through a different perspective, rather than perhaps one that you're used to seeing every day if you work on these kinds of settings.
I totally agree. And it was like I said to you, for me, that was the bit that I wish they would have focused on more. Because for me, reading it, somebody who's on a given ward almost 2 days a week, let's be honest, with my clinical academicness, and I run across these patients quite regularly, and it's Tuesday, so it's not abnormal. And it's about this paper actually shone this massive spotlight on it. And for me, it's like, oh no, it's not Tuesday. That isn't normal. That isn't okay. And how much the overriding system of how institutionalized in the NHS and likely in other hospitals in the world, we force patients and staff to become, so that these not so great experiences are normalized and accepted as, well, we can't do anything about it because I have to do my medication round between 8 o'clock and 10 o'clock because otherwise I'll interrupt the doctors, and Mary might not want to take her drugs until 11 o'clock, and if I waited till 11 o'clock she'd take them just fine, but she's in bed too, so she's getting them at 8:15 whether she likes it or not. But on the flip side of that, if we were to adapt that plan, how much then would this resistance and burden that patients are currently experiencing be transitioned onto the staff and the healthcare system? And is that actually acceptable as well? So it really made me think, this paper, like I really enjoyed it. And it made me kind of, again, shift your perspective, use a different lens to look at that problem and see whether or not it's good, bad, or otherwise.
Yeah, I mean, I'm just because this discussion is really interesting about the findings. When we looked at the kind of the rest of the comments on this tool, that actually they did integrate prior work in the discussion, and they did look at the implications. There was not very much consideration about limitations, but I think that's often the case in papers, that you don't always want to write all the limitations down, and so it would have been perhaps better to have a bit more information there. But if we come back just to the findings, because we've got about 5 minutes left, so we come back to the findings, that was the kind of key finding, wasn't it, Emily, in this study, that the way that the kind of institutionalized way that we approach care and the structure that we impose on the wards doesn't meet the needs of these patients.
Yeah, absolutely. So it talks about how so the two themes are, one is the resistance, so actually how often resistance is happening, and it talks about both physical and verbal resistance. And then it goes on to highlight two key times of the day where that resistance comes through, and that's during meal times and during medications. And the second theme goes on to talk about actually the routines, and like you said, that institutionalized nature of hospitals and how we expect our patients to fit into the routines of our hospital wards. And it's really interesting because it's so, it's true. And if you look at the literature that was being published in 1920s, it was true then, and it's still true now. So we've done nothing about it. And a lot of the training that I do in the hospital is about that, these environments are not readily prepared for that patient population. And actually, that isn't our primary aim, it's physical health. So then when you try to support nursing staff or any staff to provide care for that patient in an environment which isn't conducive to good care, it's really, really difficult. And the thing I like about this paper is actually it talks about the problems as a system. So a lot of what you read is about staff actually not doing a good job, but it's more about that the system doesn't allow them to do a good job. So for me, that's the most powerful thing that comes out of this paper. Actually, it isn't the nursing staff's fault, it's the fact that the system is so non-conducive to allow staff to provide that care.
Yeah, and actually that's brilliant, Emily, because you've really just hit the so what on the head, which was my next question, which was what should be the implications for practice from this work, and I think that summarised it really, really nicely. So I think when thinking about this paper, it's like, yeah, there's some absolutely fantastic things to think about in it, but we just need to be cautious that we don't fully understand all of the methods that have been employed in order to collect this data, and the things that might have had an impact on those aren't completely clear in this study. So thank you very much both for joining for the podcast, and for anyone else who's listening. All our contact details are in the description below, and I will also put a link about research paradigms in there, so that if anyone's interested, they can have a look and see.
I might read it myself.
Yeah, see how close to correct our definitions were. And then, but if you'd like any more information about either clinical academic careers, research in practice, or about dementia, feel free to get in touch with any of us. And we'll see you next month for the next topic in the Reviewing the Evidence series, which is medicines management. So thank you very much, everyone, and we'll see you soon. Bye.
Bye.